Thank you for coming out on a Saturday. I'm going to take a slightly different approach towards mobile applications. I think just a quick background. My name is Abhishek. I come from healthcare. Founded a company called Wealthy Therapeutics last year. We are the first mobile application that has been endorsed by the RSSDI, that is the Indian Diabetes Association, as an app that can be prescribed by doctors to patients on the prescription pad. And what I want to talk about is essentially a new category of medicine, a new category of digital health that's coming, which combines technology and combines scientific rigor and puts it together to improve the only thing that actually matters, which is better patient outcomes. And this category of medicine that we are pioneering here in India and in Asia, and there are others like us who've started this journey well before elsewhere across the world, is called digital therapeutics. So the journey is just to talk about that. I'm sure you have seen lots and lots and lots of applications. बहुत लोगों ने बताया होगा. Everything from Candy Crush to Facebook to every other health app wants to do something or the other. But for the doctor fraternity, one thing is very important. All of this, if you are going to risk either your data or your patients to look at these applications, to try out these applications, and to be able to have faith that these applications are going to work, there is one missing thing which you should be asking every application in that category. How can you prove that your application improves my patient's health better than I can, or enhances the way in which I can improve my patient's health better? There are e-pharmacies out there, dime a dozen. There are e-diagnostics there, dime a dozen. There are practice enhancement softwares out there. There are doctor booking platforms out there. बहुत सारे हैं. But why aren't we asking a question of where are the mobile applications that can improve my patient's health as an extension of my practice? That is the problem that we started solving about a year back. And we looked at diabetes because it was a really, really large problem to solve. But most importantly, it was a combination of continual care and mathematics. And an application at the end of the day is code. It's software. It is a logic system. And unless there's a logic system that can play a role in disease management, that application has no role to play in patient outcomes, at least to the point where it starts intervening. And we believe that intervention in a world of episodic care is necessary for diabetes. So you look at the last 20 years, and you will notice that billions of dollars have been spent, pharmaceutical, medical devices, and a show of hands that in the last 20 years, all that innovation later, A1C levels, I mean it's already there on the board, but A1C levels are exactly the same. Number of diabetics has tripled, A1C levels are exactly the same. So clearly what is happening isn't enough. And here's the best part. Short term or long term lifestyle and behavioral intervention has been proven to have extremely high change in the patient's outcome. Not just when you track it 2 years, 1 year, 5 years, 10 years, 15 years. There's now 20-year data to prove that versus a control group, lifestyle and behavioral intervention, even if given in a regimented way for a short term, is incredibly, incredibly powerful. And this is why it's so powerful. Sorry, just to set context, there are companies that have been doing amazing, amazing work. They have gone randomized control trials, patents out there to prove that this can actually happen, which with actual documented scientific evidence in the New England Journal of Medicine, in the BMJ, in all these other places of repute where you can show and prove to the world that what you do works. When you are able to change A1Cs by more than 0.5, life changes as far as cost of care is concerned. You change A1Cs by more than 1% and complications go down, risk of death goes down, risk of cardiovascular complications goes down. Extremely, extremely high impact, right? But that digitally delivered continual care in India still remains a myth, because either there is extremely high resistance, it's an out-of-pocket market, therefore you need to have a very, very, very low cost to make this happen. There is no infrastructure on the ground, and frankly, the care providers don't have the time. They want to do it. Time ki line is there outside the patient, outside the doctor's clinic. And if you combine all of that with the fact that the patient himself or herself is not tuned to improve their health, they want to go have medicines and go home, and they don't see the long-term consequences of that. That's a challenge. But what was also missing, and two very important things have happened in the last 5 years in India that has now made this a reality. Number one, the smartphone is in the hands of a very large volume of people, and connectivity has come with that. That's one side. And the second side is that artificial intelligence is now of a level where you can start having logic systems that learn at a personal patient level. It is not something that is individualized, generic text content, paper content. Every single patient can be individually treated, and as data points come of that patient, that treatment regimen can be automatically changed. And when I talk about treatment, I am not talking about drug therapy. Drug therapy remains and will always be a physician's role. Nobody else can come and claim that. But what happens when that patient leaves the doctor's the doctor's clinic? He's expected to be adherent, expected to eat proper, be more active, blah blah blah. Hota hi nahi hai. You know it, I know it. He's expected to come back to the doctor's office every 3 months, 6 months. They don't come back until there is another problem. So how do you make sure that you combine all of that, but you also make sure that you cater to the ground realities of India? And the ground realities of India is very simple, boss. I want on demand and I want cheapest cost. If continual care is delivered face to face or even over the phone, it's too costly. It just cannot work. It's also too inconvenient because the person has to be available on the phone and all of that. But what happens when you let artificial intelligence take a role? You not only have very cost-effective cost of care, but you also have a paradigm shift in the sheer amount of population that can get access to this care. Now, whether it's an unaffording patient, an affording patient, an obese patient, a thin patient, a type 2 diabetes on oral, on insulin, doesn't matter. You can cater to all when you make artificial intelligence start playing a role in this world of new medicine delivered digitally, which we call digital therapeutics. And most importantly, any solution that you see out there, before you prescribe to your patients, you must ask one question: show me data. Show me show me how yours works. And I must say that we are not yet there where we'd ideally like to be. We conducted a small pilot. We took 42 patients, average A1C of 9.06, average age of 48, male-female ratio 2:1. But here's the important part. We recruited them from the doctor, normalized for prescription 60 days in advance. That means there was no change in prescription, and made sure that for 16 weeks, we did not speak to them on the phone. We never met them face to face, and the entire program and entire intervention was carried completely 100% through an app. And we were able to, at the end of those same 16 weeks, see an A1C reduction of 1.04% without any change in prescription. And this is the beginning of what we call digital therapeutics in the world of type 2 diabetes to start with. Because there truly is continual care possible, relevant, important, but when you deliver it to the patient in a manner in which it engages the patient, keeps the patient happy, delivers it in a medium in which the patient understands it. Don't try to give it in lengthy paragraphs or give it in booklets or pamphlets where, aata hai and throws it away as not there in share of mind. But when you start doing it in a manner in which it is on demand and relevant to that patient, life changes. So when you combine 1, 2 and 3, this is what happens. This is what we call the first cut of our AI platform. It is an artificial intelligence driven solution. Diet, exercise, activity, blood sugar, weight, diagnostics, prescription, sleep, and intermingling all this data in a manner in which you solve for continual care. Continual care is where life changes. Continual care is what is missing in a doctor's practice, and continual care, when you enhance a doctor's practice with continual care and you ensure that you can give it to your patients as an extension of your practice, you can see that extremely different patient interactions happen. It not just happens over an app, but what you start getting is paramedical support, which was non-existent earlier. You get access to a diabetes nurse, a certified diabetes educator. a nutritionist, a fitness trainer, behavioral counselor, things that you know your patients need but you're unable to provide, but you can now personalize it and make it on demand for your patients as an extension of your care. And this is when you start doing that as an extension of your practice, then something incredible happens. What starts happening is that you can prescribe continual care. You can prescribe lifestyle and behavioral modification. You can prescribe what you could not put on the prescription pad, because at the best you were giving instructions but you could never see if there was compliance. And what you'd also do is you make sure, at least we do it and others should do it as well, is you please remember that at the end of the day the patient is that doctor's patient. And therefore that relationship should never be with Wealthy or with any company. It should be an extension of that doctor's practice. This is important, because when you combine the two, you now have an enhanced doctor-patient relationship, you now have better outcomes, and you now have the patient escalated at times when it matters the most. So not 6 mahina ho gaya wapis aao. It's although that is always there, it is also a, hey, I'm noticing an alarming rise in your blood sugar. Hey, I'm noticing that your carb content in your breakfast or your lunches are very high. Hey, I'm noticing that your activity levels have been declining over the last 2 weeks in a row, and you're on less than 30 minutes a day, which is what has been prescribed. What the hell are you doing? You have much more instances, clinical instances, to be able to call that patient back. And AI can solve for all those queries on your behalf. You now have paramedical support, real-time on-demand, with logic systems that cannot fail, that allow for all those WhatsApp messages, all those queries, all those phone calls to be catered to without you having to lift a finger. But most importantly, because you have been able to enhance your care to your patients in a manner in which it improves patient outcomes. Because two things happen. One, continual care is brought to the table, and therefore on-demand continual care is available 24/7. And the next is when the patient comes back for a follow-up appointment, that appointment has an incredibly large amount of data, which is not just analyzed and looked through, but there's decision support on that data, which is telling you exactly what is going wrong in that patient's life and what could you do. And at the end of the day, it still keeps the power in the doctor's hand, as how can I now use this additional data to be able to fine-tune the advice I give to my patient and fine-tune the prescription I give to my patient, because now I have more data than I had before. The power is endless, right? Go regional with it, go across platforms with it. Start, while this is diabetes right now, why not pre-diabetes? Why not blood pressure? Why not cardiovascular? Why not COPD? The world is endless, but let's make sure one thing, that in this world of digital therapeutics, which is a new category of medicine which must be governed by science and must be regulated, because it is an intervention at its core of it. It's not medicinal intervention, but it is behavioral and lifestyle intervention nonetheless. Let's make sure that data, clinical trials, and logic systems that cannot be broken are first there before this is exposed to patients. Because there are challenges, right? What happens to patient privacy? How do you control that? How can you govern any entity, whether it is Wealthy or any other company, to make sure that my patient data never goes to anyone else? I do not, and you cannot screw around with patient data. What happens in emergency events? Yes, we can detect hypos. Yes, we can send an alert to the care provider. We can send a Google Map link. We can do a lot of things. But who takes liability? Those are questions that deserve to be answered. But in all those answers, let's not forget that there is care that can get better. And you can truly bring continual care back into your practice in a way in which it enhances patient outcomes, it enhances your practice, enhances the quality of your relationship with your patients, improves outcomes, and improves, hopefully, care overall in India and outcomes at a population level. That's digital therapeutics, and I thought that let me introduce it to this audience. Happy to take any questions, but it's a new category of medicine, and I hope that you see lots more of such enterprises to come. Wealthy is one such of those in that journey, and would be humbled and privileged to have your support along the way. That's it. Thank you. So specifically type 2 diabetes, not even diabetes. So no gestational, no type 1. Yeah. No, absolutely. We would love to. We are just very clear on this. We consider that we are building a drug, and thereby we want to go an inch wide and a mile deep. Be very, very good at what we do, right? So we already have it. So I'll no, both. So what happens is, so we work with insurers a lot. So and you'll see this live in 2017. That with insurers, what happens is there's a two-layer escalation matrix. Layer one is within the app, where in case there is a hypoglycemic value, so we have Bluetooth connected blood sugar devices, right? So when you put in, even if you are disconnected, you put in the value, what will happen? If it's Bluetooth connected, even better. And what you have is that as soon as the event is understood, there's an emergency event that is understood from the app side. So the app doesn't coach you, the app escalates that this is an emergency event. Please understand that this is a very low blood sugar reading. As soon as you confirm, we coach the patient on what to do next. But most importantly, an SMS is also sent to the patient's care provider with GPS coordinates. It's a Google link which tells the care provider exactly this patient is suffering a hypoglycemic alert. This is the GPS coordinates, because that care provider has been nominated by the patient. And in practices where the doctor opts in, because it has to be opted in by the doctor, a second SMS goes to the doctor as well, or the doctor's care team. But that's optional. That's in case the doctor feels that is the case. For insurers, we have a second layer of escalation where we have human paramedical support sitting within our office 24/7, and we escalate it on their behalf. But that's obviously with an insurer, because there is a further level of regulation that we want to comply with. Yeah. Yes. Yes. Of course, but that's why it's not one person, right? It's a team. Yeah, yeah. It's very scalable, right? So what happens is that yes, today, as of today. So the infrastructure is all in Mumbai, and we yeah. So server. So we have two server rooms, right? There's physical servers, and then there is cloud. So the Amazon infrastructure and IBM Watson, which is our cognitive computing infrastructure, is all on the cloud. In what way? I mean, we're happy to offer our services, but I mean, I guess the IP is still IP, right? So we'll keep the logic system behind closed doors.
You need somebody who's really a technical person supporting you, like IT people also.
That's our team. So our team is made up of clinicians, which are split into two parts. We have behavioral scientists, we have diabetologists on one side, we have our entire clinical research team, and we have paramedical support, so diabetes educators, nutritionists, diabetes nurses, all of those. That's on one side. Then we have a design team, and then we have our largest team, which is our technology team, which is split into artificial intelligence and then infrastructure technology. So that's our team. And then we have an advisory board above us, which makes sure that everything we do, every logic system we build, is something that is globally compliant. So it needs to be compliant with ADA guidelines, American Diabetes Association guidelines, IDF guidelines, and RSSDI guidelines. So
I think we should congratulate you for the fantastic job.
thank you. Thank you so much. Hopefully, sir.
Any other, I mean, if you have COVID, diabetes,
No, it is. I think we're baby steps. We just launched in December 2016 with the RSSDI endorsement. So until that point, we couldn't even go live. It will be, sir. But like I said, for us, we will always remain prescription, which means that. So what happens is we plug and play continuous monitoring. Yeah. So different markets work in different ways. So for example, we are also working in other markets in Asia. We go live in the rest of this year, and we also are working in the Middle East. India is an out-of-pocket market. So what happens over here is patient has to pay doctor and so on and so forth. With insurers, insurer pays, because at the end of the day, insurer gets to reduce risk. So what we're working with the insurers on is how can we get a 30,000 rupee 5 lakh cover diabetes product down to 15,000 rupees, because now we are able to get the patient safer, right? In what sense? Yes, absolutely. So what happens is but what's very important is there's data privacy and there's data portability. So we will never allow, say, Dr. 1 to see patient A to share data with Dr. B unless they've authorized Dr. B on the platform. That's number one. Number two is data goes both ways. The lifestyle data goes to, say, a system like Practo, and vice versa as well. Doctor has to give consent, because at the end of the day, that's in the doctor's control. Absolutely. Patient consent is, so when the patient signs up, there are two consent forms that we have for any patient. Number one is that you consent to ensure that this data can be used to make the app better in a de-identified way. Two is this app can be used, this data can be used for medical research. So we get two consent, and what with that happens is, and within that, is that the data can be shared with your primary physician. If the patient says no, that I do not want to share my data with my primary physician, he is not allowed on the platform. Very simple. If it's a no-brainer for us, we believe that the physician has to be empowered with this data for the patient outcome to improve. So doctors prescribe, sir. We don't do B2C at all. So the step one is the doctor onboards his or her practice onto the platform. And we have a contract that we sign with the doctor. Step two is that doctor prescribes that app to the patient, who in turn can download the app. So there are two layers to the app. There is a free non-prescription layer, and there is a prescription layer. The free non-prescription layer anyone can use, but that we are not necessarily, that's free, right? Anyone, no problem, please use it for the rest of your life. That's our responsibility back to India to give. But the prescription layer, unless the doctor writes it on the prescription pad and authorizes that prescription, no way. You cannot get access to it. So he gets a code, which once he puts in, he is able to unlock the prescription layer of the app. And what happens is, in the prescription there are two parts. One is that from the Play Store. So what happens is, we've built deep linking technology that understands each unique code back to the doctor. So we are able to trace the code back to the doctor who gave the code, and only until that verification loop is complete, you will now not be allowed into the prescription layer of the app. So yes, we are figuring that out. We're working with doctors to get that answer to that. Once I have pricing, I will let you know. Yes. Nobody else. We will see de-identified. So of course, because otherwise we won't be able to do the work. But yes, nobody else. So the way it works is, we want to restrict physicians, or rather optimize physicians' time, which means that a patient will get access to the report and the doctor will get access to the report, so that at any given time the doctor can log in and see the data. But more happens more likely is that the doctor, when the patient comes for a follow-on appointment, will either get a one-page form, or on the doctor's mobile app they will be able to see that patient's data. So that's how we keep the involvement today. For doctors who want to be more continually involved, we have a live chat availability, which we integrate in as well. It's easy as well, it's already live, but what tends to happen, sir, is that it's blatantly misused by the patient, and therefore we're trying to figure out the right way to make that work. Cool. Thank you. Oh. How would you give an authorized person to prescribe the app in the sense? So today because today because we are still building our security layers from a doctor perspective, the doctor needs to sign up with us. So what we are trying to work out with the RSSDI is, how can we make it available by default.